Myself Pankaj Ghatbande, on the behalf of NACO, I welcome you all. Thanks a lot. So this is our first session, which is titled Overview on HIV-1 Viral Load Testing. And in this session, we will discuss on the routine viral load testing, eligibility criteria, and timelines for the HIV-1 viral load testing. We will also discuss on the ARTC linkages to the HIV-1 viral load labs. So this is the 95 targets, and the numbers or the estimates are already displayed on your screen, and these numbers are for last 3 years, and all of us know 95. This is an UNAIDS ambitious targets of 95, which the first 95 is all people living with HIV to know their HIV status. Second 95 is 95% of all people with diagnosed HIV infection to receive the sustainable antiretroviral therapy. And third is 95% of all people receiving antiretroviral therapy to have their viral load suppression. Now, ART centers play a crucial role in this particular ambitious target, especially on second 95 and third 95. And if you can see here, the third 95 talks about the viral suppression. So if the patient who are on ART medications, they should be tested routinely on the viral load testing, and the viral load test and their viral load should be suppressed. We will see in the future presentation what is meant by the suppressed viral load. So here the ART centers role is very crucial. The samples are collected at ART centers. They will be processed at ART centers, and they will be transported to the viral load laboratory. And if this is the pre-examination process, and if this pre-examination process is appropriate, then only the testing results are accurate and reliable. And then only we can able to say, or we can able to estimate, devise that whether the patient is suppressed or not. If that pre-examination process is not appropriate, then our final outcome or this data is not reliable, right? So again, I will repeat that the role of ART center is very crucial in this 95 target. Now we will see how this antiretroviral therapy affect on the viral load as well as the CD4 count. As you know that when HIV enters into the body, it starts multiplying, and when it enters into the body, our body try to kill, and the cells which try to kill the HIV virus are the T cells, TCD4 cells. Now, this HIV also attack on the TCD4 cells. So HIV kills CD4 cells, and CD4 cells try to kill HIV virus. Okay. When you can see here in the graph, the green line is the virus. Virus enter into the particle and start multiply. So within a week, the viral load is at its peak. And once the immune system, that is CD4 cells and these T cells, the lymphocyte cells, immune cells, stabilize, they start fighting with the cells, and then they bring the virus under control. Okay. But this process goes on. But if the patient is put on the medications, that ART is also killing the HIV virus. And in this way, the HIV virus is in control when we are giving the ART to a PLHIV patient. When the virus, if there is if the patient is not on a treatment, or there is no adherence, or there is a treatment failure, then virus will not have any restriction and it will start propagating and it will start replicating. What will happen? But if the virus is replicating, it requires the CD4 cells to replicate. So it will infect CD4 cells and it replicate. So that means it will enter into the CD4 cells and it will replicate, and then when it come out, it will kill that particular CD4 cells. What it means, the virus will grow and it will be inversely proportional to the CD4 cells because it is start killing the CD4 cells. So CD4 will get decreased and viral particles will get increased. So the proportion of viral particle and the CD4 is inversely proportional. One goes up, other will go down, right? Likewise. So coming to this particular table, you can see here with the ART initiation, if the patient is on ART, the viral load will drops, the virus particle will drops. And what will happen if virus is under control, our CD4 cells increase. So CD4 count, if we test that blood sample with the CD4 cells, CD4 testing, the CD4 count will rise. What it means? That patient starts recovering. Immunity is increasing, patients will start to recover, and because immunity is strong, the opportunistic infection will be prevented. Okay. On the other hand, if you see the other column, with the with treatment, if the patient is on treatment but there is a non-adherence or there is a treatment failure, what will happen? If the patient is on non-adherence or patient is not taking the ART regularly, then that effect of ART on the virus is not optimal and virus again start proliferating. Virus again start multiplying. And if we test that particular sample for the viral load testing, we will see that rise in the viral load count. And if the viral load count is increased, what will happen, as we have discussed, that it will start killing the CD4 cells. And at the same time, if we test that sample for the CD4, we will see that the CD4 count drops. And what will be the ultimate result? The immunity get weaker. And if immunity is weak, what will happen? The opportunistic infections will occur to the patients. So this is how the effect of antiretroviral therapy on the viral load and CD4 count. So then what is viral load now? Specifically, what is viral load? So viral load is a plasma HIV-1 viral load. Refers to the number of virus particles found in each milliliter of blood. So how many virus particles are there in each milliliter of blood that is being tested by using plasma of the patient, and the test that is utilized for this is HIV-1 viral load testing, which is RT-PCR. Okay. And when we test this sample, the result is reported as number of copies of HIV RNA per milliliter. So that RNAs, number of RNAs present in that particular plasma is being counted, is being detected and counted by the test, and that estimate copies per ml in copies per ml is reported. So what we have discussed in earlier slide is higher the HIV-1 particle in the blood, faster the CD4 cell depletions and faster the progression of AIDS. So if we test the sample for the HIV-1 as well as for the CD4, if HIV-1 viral load is high, that sample, when we test for the CD4, we will see that low CD4 count because these two parameters are inversely proportional, right? So this is what is why we are discussing this, because there is also a targeted viral load. Okay, so what is routine viral load? Previously, the viral load was tested as a targeted viral load. Only specific patients with the treatment failure were tested for the HIV-1 viral load. And the disease progression was tested or was monitored by the CD4 test. Now, in WHO in 2013, in the treatment guideline, recommend viral load test as a preferred test for monitoring the antiretroviral therapy and also for the early diagnosis of the treatment failure. So previously CD4 was the test for the disease progression, for monitoring the disease progression, but WHO has recommended the viral load test as a preferred test for the early treatment, for the diagnosis of the early treatment failure. And this was adopted by Government of India, and Government of India launched the viral load test to all the PLHIV on ART in February 2018. So now the viral load test from February 18, viral load test was performed as a routine viral load test monitoring. It was not targeted. Okay. So as we have discussed in the introductory session, there was a public-private partnership where the private laboratory was also partnered for HIV testing because number of PLHIV tests were more to take up that load. Private partner was also chipped in, and we were also, the NACO was also simultaneously building, operationalizing the NACO's viral load testing laboratory network. So now the 64 viral load laboratories are established, and as NACO, Smita from NACO has also said that from next month, we will have the all public sector viral load laboratories will test the samples from all over India. So now for the routine viral load test monitoring, what is the eligibility criteria? The eligibility criteria is the patient should be HIV-1, all HIV-1 patients who are registered under the program. This is important, who are registered under the program and they are on ART for last 6 months. They are eligible for HIV-1 viral load testing. Other criteria is HIV-1+2 co-infected patient. These patients are also eligible for routine viral load testing. Those patients which are having HIV-2, they are not monitored by the HIV-1 viral load testing in India. Okay, this will be excluded. So for the HIV-1 viral load testing, if the PLHIV is visiting to the ART centers, one must see that what is their serology status, whether he is HIV-1, HIV-1+2 or HIV-2. If he is HIV-2, this patient should be excluded and patient sample should not be collected for the HIV-1 viral load. There may be one question from you, then what should we do for this HIV-2 patient? How we will monitor the disease progression? So we are having CD4 testing. We are not stopping this CD4 testing. So we will be doing the CD4 test for all these HIV-1, HIV-1+2 and HIV-2 patients also. But apart from that, preferred test for HIV-1 and HIV-1+2 co-infected patient is HIV-1 viral. Okay. Now, what is the timing for the CD4 viral load test as well as the CD4 test? So we will divide this into portions. First is for all patients who are on the first line ART. So the timing for the viral load test is after initiation of the ART, first viral load will be on 6th month and then 12th month. So after initiation of the ART, first test will be at 6 months and then 12 months, and thereafter the viral load test will be done annually. So next will be on 24th month, 36 months, 48 months, so on, right? So this is for the patient on the first line ART. The CD4 test for these same patients will be done 6 monthly. Okay. Now for the patient on the second line or third line ART, the First viral load will be at the assessment, and then it will be 6 month, 12 month, 18 month, 24 month. That means every 6 months. So for the second line and third line ART, the routine viral loads will be at every 6 months. And similar to the first line ART, CD4 test will be 6 monthly. So there is no change for the first line and second line and third line for the CD4 test, but there is a change in routine viral load test for the first line ART patients and the second line and third line ART patients. Now, this is very important that we are testing the samples for the viral load as well as CD4 test. And these samples will be collected from the patient using a single prick. At the same time, whenever there is a viral load test, the CD4 samples and viral load samples will be collected using a single prick, same test. And when we are collecting these samples at the same time, the report will also be generated, and based on these reports, we will decide, the ART will decide whether to conduct the CD4 test further or whether to stop the CD4 monitoring. And the condition for this is, if the CD4 count is greater than 350 CD4 count and viral load is less than 100 1000 copies per ml, then the CD4 test can be stopped. But this condition is for those patients who are above 5 years. So this condition is not applicable in children's age less than 5 years. Okay. So now we have one quiz. The quiz will appear on your screen, and you have to answer by submitting that, and you will get 30 seconds for that, and then we will discuss this. Correctly answered this quiz, and the answer is true. Okay. So for all patients on the first line ART, the viral load will be conducted at 6 months and 12th month, and thereafter it will be every 12 months. Okay. So we will move on to the next slide then. Okay. So now, as we have discussed that from the next months, the viral load testing will be conducted at 64 viral load testing laboratories established by NACO. And these viral load laboratories are spread all over India, and the linkages for these viral load laboratories for the respective ARTCs has already been established by NACO, and that are already communicated to the SACs. It may or may reach to you, it may have reached to you, or it will reach to you through the SACs. But broadly, we will see for the states that are included in this training, what is the linkages. So overview we will see, but before that, we will see how these linkages were planned. So the first criteria that was considered for linkages was the proximity of the ARTCs to the nearby laboratories. If the nearby laboratory is having spare capacities, all the nearby ARTCs were accommodated. If it is not, then the spare capacity of nearby lab, which will be a second nearest viral load laboratories, was checked. And if there is no spare capacity in the second nearest lab also, then the preferred intrastate or interstate linkages was established. So these were the criteria that was used for the linkages. And the linkages, heading, the title of the slide is wrong. It is for the states that are involved in this. But you can see the states. The Assam is linked to the viral load laboratory IBAS, Delhi. Dadar Nagar Haveli is with GMC Surat. Meghalaya is with the RIMS Imphal. Mizoram is with Mumbai, which is viral load laboratory Kasturba. and Puducherry is linked with the viral load laboratory from Tamil Nadu, which is NRT Chennai. Arunachal Pradesh, Nagaland, Sikkim, Manipur, and Tripura are linked with the RIMS Imphal. And for the Tamil Nadu ARTCs, all the Tamil Nadu ARTCs are linked to the respective laboratories in the Tamil Nadu. There are 7 laboratories, and the linkages is according to their criteria, as we have discussed. So all are linked in the TN viral load laboratories. Now, as we have discussed that for the viral load laboratory testing for the PLHIV, the ART center's role or the pre-examination process is very important. And where the pre-examination process is being performed is this at ART centers. And what ART center will do? Before discussing further, I just wanted to mention that previously there was a co-located and non-co-located ARTCs criteria was defined. The those ARTCs co-located were sending the whole blood samples. Now that criteria is not available. Now all the ARTCs will collect the samples and separate the plasma and transport that plasma to the respective viral load laboratories. There is no criteria for co-located and non-co-located. All will transport the plasma only, no whole blood. Okay. So what is their role is sample collection for the HIV-1 viral load test. That it should be according to the schedule. It should be collected with the single prick for the CD4 as well as viral load. And after collection of sample, they should aliquot the plasma. They should record the necessary details in the viral load register as well as the IMS. Then they should prepare and coordinate for the sample transport agency. At Smita has mentioned that the sample transportation agencies is already recruited by the states that will be communicated with you. And then when the samples are transported, if there is any discrepancy by the viral load laboratories, that will be communicated. So ART center's role is to resolve that discrepancy within the time frame and communicated back to viral load laboratory so that that particular samples will be tested by the viral load laboratory in time. And the receipt of the report from the viral load laboratory and entry into the respective registers and other forms. These are all important steps that are to be performed at the ARTCs, and these are very crucial for the patient services. Now, as we have discussed that the pre-examination is being performed at the pre-examination process are performed at the ART centers and examination process are performed at the viral load laboratory. So the laboratory clinical in between these two entities is very important. And what is laboratory clinical interface? It implies the bridge and linkages between viral load testing laboratory and the ART centers. So here both viral load laboratory staff as well as the clinical staff at ART centers have equal responsibilities for providing the appropriate and desirable services to the patient who is attending the ART center. Okay, and this is very crucial for the successful implementation of the viral load testing under the NSCP program. So there is a major requirement of a coordination. This is very essential that there should be a coordination between viral load laboratory and ARTCs for quality patient services. Okay. And ARTC should coordinate with the viral load laboratory also. And there are one more stakeholder now, a sample transportation agency. They should also coordinate for the scheduling the sample transport. So this is very important. Communication and coordination is very important. Okay. So we have discussed the overall process, and the key points are from February 2023, all viral load testing will be done in the public sector viral load laboratories. And to take up this load, NACO has established 64 public sector viral load laboratories, and the ART centers are linked to the respective viral load laboratories. The linkage plan is already been established, and that will be communicated to you, or must have been communicated to you. To perform the HIV-1 viral load test, eligibility criteria is already defined, and all ARTCs must follow that particular criteria, where the HIV-1 and HIV-1+2s are tested for the viral load testing, but HIV-2 are not tested, and there will be monitored only by the CD4 test. The timing for viral load test and CD4 test must be followed by the ARTCs, and whenever there is a viral load test and CD4 test, both the tests are referred by the clinician. The sample must be taken at the same time with the single prick. So this ends up our session. So if there are any queries or more information is needed, or anything else, I am happy to answer. Please let me know. Thank you. Question in chat box: for second line patient, if CD4 is greater than 350, can we can stop taking CD4? Yes, as we have discussed, this condition is for both, whether it is first line ART or second line ART. If the CD4 is count is greater than 350 and viral load is less than 1000, we need to stop CD4 testing for that particular patient. But the condition is the patient should be more than 5-year-old. This is not applicable to the patient who are less than 5-year-old. I think